evening, everyone. Thank you for coming out tonight. My name is Dr. Seth Cohen. I hope you're enjoying your dinner. I would like to have some. I don't want to share with you. I'll take my own later. My name is Dr. Seth Cohen. I'm a medical oncologist. I want to personally thank the Naris Foundation and family for sponsoring. This is the fifth of 5 events to be held this year on the academic calendar through June of 18 to June of 19 for presenting to the community with free dinners, I might add, speeches and lectures on oncology and topics in oncology for the community to benefit the community and to learn about oncological issues. We've had talks on gastrointestinal cancers and colorectal cancers in specific. We've had discussions with breast cancer and lung cancer as well. And this is the final lecture on this series, and we'll start again in June of 2019 by going to the Naris family another series of 5 lectures. So I want to personally thank them for all their support. Tonight we're going to be speaking about colorectal cancer, and I'm pleased to introduce my colleague, Dr. Akhtar, who's a gastroenterologist at Stool Gastroenterology Associates, locally here in Oakhurst, New Jersey. Before I read off his accolades, I just want to tell you that he's an excellent physician, and anyone who needs gastrointestinal care, he's the guy I send my patients to on a constant basis. He's always accessible. I call him on his cell phone, and he knows that. And he answers his cell phone and gets my patients in a timely fashion. So I want to thank him for being my colleague and helping me out in the community and being an excellent physician. Dr. Akhtar went to Rutgers University, where he graduated with high honors as a Henry Rutgers Scholar. He completed his medical degree from Tufts University of Medicine, and he did his internship and residency at Mount Sinai Hospital in New York City. He was chief resident while at Mount Sinai, and he continued both his fellowship in gastroenterology and hepatology, where he as a chief fellow. He did further training in EUS and ERCP, which is techniques he may or may not discuss tonight, but those are techniques we use for helping patients to stent and do various other procedures. And I want to give a warm welcome to Dr. Akhtar and thank you for coming out tonight.
Thanks, Dr. Cohen, for those kind remarks. I echo, all the sentiments you said about me in terms of our professional relationship, but not as well spoken as he is. Anyway, thanks for being here tonight. Again, my name is Dr. Reza Akhtar. I'm a gastroenterologist on staff at Monmouth Medical Center, part of RWJBarnabas, and then part of a private practice, short gastro, right here up in Oakhurst. So tonight I'm going to be speaking to you on colorectal cancer screening. My part of the talk will focus more on diagnosis and initial staging and some of the things you can sort of see and expect up front with this unfortunate disease, and then we'll transition over to Dr. Cohen's portion of the talk. We'll talk more about the actual treatment strategies available for patients.
A little louder, please.
Oh, I'm sorry. How about now? Is that better?
Yes, it is.
All right, sorry about that. All right, so a lot of trepidation about colonoscopies because a lot of people picture it something like this. And as someone who does colonoscopy pretty much every day of the week, and I can assure you that once you are sedated, the scene is nothing like this. First of all, you're asleep. And second of all, it's not that big, I promise. So just to move along with the outline of the talk, we'll first talk a little bit about the burden of disease, why we're here tonight, why we are gathered on, in March, which is Colon Cancer Awareness Month, by the way. Talk about current screening guidelines, what we need to do and what's available in order to detect cancer at an early stage and or prevent it. What methods are out there for screening. Talk about early detection, finding it early enough and why that's important, and then I'll briefly summarize. So I'll try and move through this quickly so we can not keep you here too long. So the burden of disease. The reason, again, that we're here tonight is because colon and rectum, cancer of the colon and the rectum is very common. It is the 3rd leading site of cancer in both men and women, depicted here on the left and right. And not only is it very common, it is also unfortunately associated with a high mortality, it being the 3rd most common cause of death from cancer in both men and women. These are graphics, by the way, from American Cancer Society. They're readily available to the public, and they publish a cancer report every year. And it's very helpful information and gives a lot of statistics on cancer from all sites. But these are the specifics for colon and rectal cancer. And we do lump those two together because they generally, obviously, they're of a organ that is in continuity, with the colon and the rectum being the bottom of the colon. They do have some different treatment strategies, but generally most of the statistics I'm going to talk about are the group as a whole. Colon and rectal cancer death rates are decreasing, and we see that in these curves all coming down, which is a tribute to people like Dr. Cohen, who have worked tirelessly to help treat these patients once they are diagnosed. And of course advances in different types of chemotherapeutic agents and other treatment strategies for colon rectum cancer once it's diagnosed. That is true for both men and women, and that's what those two slides showed there. The probability of cancer by age is depicted here, and what we do see specifically for colon and rectum cancer is that as you do get older, the chances of developing cancer are higher. And that is the premise for why we start recommending colon cancer screening at the age of 50. And we'll talk about that age and how it may be changing on a future slide. But you can see here that going from birth to 49, it's 1 in 272, which is a pretty low chance. But once you get up to the age of 70, you have a 1 in 30 chance of developing colon and rectal cancer for a male, 1 in 33 for a female. So that is the reason that we bother people once they turn the age of 50, while your primary care physician is on you, while your family members, friends, spouses, whoever it may be, want you to get a colonoscopy or some form of colorectal cancer screening. It's because your chances increase as you age. So what are the current screening guidelines? How do we find colon and rectum cancer early? It's important to know what the word screening means, just to kind of frame this talk. And specifically, what it means is, and this is the medical definition, identifying disease in individuals who do not have symptoms. A lot of people who we recommend colonoscopy to, who may have been recommended to have a colonoscopy by their primary care doctor, say they feel fine. They don't have any symptoms. They go to the bathroom normally. They eat normally. They haven't lost any weight. But it's important to note that the reason that we recommend these tests is to find it early and potentially be able to prevent it from happening even in the first place. So identifying disease without symptoms is the key to this entire talk. We as gastroenterologists follow a number of sets of national screening guidelines. These are published by many different societies. There are both GI societies, governmental societies, the U.S. Preventive Services Task Force, and there are combinations of experts in the field of gastroenterology, medical oncology, radiology, and other government public health officials who give us these complex kind of lists, and they change over time and they update them whenever they feel like, but generally they follow the same premise, and that is you need some testing starting at a certain age, and then you need to repeat that testing over time to make it the most accurate to help give you the best chance. So when do we start screening, just to get to the bottom of it and what the guidelines are? Generally, in most patients, you start at age 50. The note there says that that means that you are average risk, which means that you do not have a family history of cancer. You do not have any symptoms. You do not have any genetic risk profile that may make you at higher chance to develop colon rectum cancer in your life. If you're African American, the recommendation currently is to start at the age of 45 because the incidence of colon rectum cancer is higher in younger populations of an African American race. Newer recommendations from the American Cancer Society, you may have seen it in the news this year, state that everybody should start colon rectum cancer screening at the age of 45. And actually, we just got word this week that the first private insurer, Aetna, is approving colon rectum cancer screening starting at the age of 45. So it's important to note that in our world, and in your world obviously, just because a cancer society may say something doesn't mean that a test may be covered at 100% of its costs, which is where most preventative services are bucketed. So when you have a family history of colon cancer, obviously there is probably a higher risk to you, but not everybody necessarily in that family. But in order to identify who may be at high risk in that family, you start at an earlier age, and that age is 40. There is a slight asterisk that should be there. Essentially, it's if someone has had colon cancer in your family at a younger age, you may even have to start younger than age 40. But the details on that are not really necessary for this talk. So if you have a first-degree relative less than the age of 60, you should be getting colon rectum cancer starting at screening at the age of 40. Or if you have two first-degree relatives of any age, you should also be starting earlier than the age of 50. So 50 is not a hard number for everybody. Your family, your individuality is important, and it's vital for the discussion with your doctors in determining if screening is appropriate for you. Surveillance means what do you do after you may perhaps find a polyp on something like a colonoscopy or some other screening test is positive. And so it depends on your initial colonoscopy findings, and patients are labeled as low or high risk depending on that initial colonoscopy. And the reason for that is because if you find a polyp, it increases your risk for future polyps. It means that your colon likes to form polyps for whatever reason. Combination of genetics and your environment, perhaps things in your diet, perhaps other medical problems you have. And so we want to keep a closer eye on those patients because they are higher risk to develop cancer. So once you have a colonoscopy, if you have a colonoscopy for screening, again, I'll talk about the other screening methods in a bit. If you're a low risk, that means that you don't have a polyp, you don't have any family history, you were average risk to begin with, and that's easy. Colonoscopy starting at age 50, every 10 years until about the age of 80. Now that I say about the age of 80 because there's a lot of changing guidelines on that specific topic. When do you stop getting colonoscopies? And so a lot of that depends on what was found on perhaps your screening test to that point. How you may tolerate something like a colonoscopy because it is a tough procedure, as some of you may already know. The older you get, the higher the risk of the procedure is, both from standpoint of other medical problems you may have, but also how your colon specifically will handle the instrument that is the colonoscope that we use to find polyps and remove them. Patients who are labeled as high risk are those who have found polyps on their initial colonoscopy. Now there's many different types of polyps, and this might be a little bit too detailed here, but essentially you have to come a little bit more frequently if you have polyps found on your colonoscopy or other screening test. And if that polyp is large, or if you have a lot of them, you have to come even more frequently than every 5 years. And that's generally every 1 to 3 years, depending again on what's found each colonoscopy. So each time you go through this test determines when you will need your next one. There is no hard and fast rule for you're going to get colonoscopies every 2 to 3 years for the rest of your life, unless you have some type of genetic cancer syndrome in your family or you have the same genes that put you at risk. So those are the only patients who go through those intervals, or who are recommended to undergo those intervals. So what methods for screening are there out there? I've mentioned colonoscopy a lot. Obviously, I'm a gastroenterologist, I'm biased, but there are many other different types of screening tests out there. And when we talk about screening tests, it's important to know the difference in terms of their performance, what they can do for colon and rectum cancer. Can they prevent it, or are they just detecting it once it's already present? And so prevention, I would think, in most people's minds, is preferred to a test that detects colon and rectum cancer. And so these are the tests that we have available today. Those that prevent cancer are generally invasive and do involve colonoscopy, sigmoidoscopy, which is kind of like a half colonoscopy, and something called CT colonography. Many of you may have heard of this and refer to it as the CAT scan version of a colonoscopy. Those are tests that have been proven to prevent colon and rectum cancer. Tests that diagnose cancer that is already present are generally stool-based testing. And I'm sure many of you have seen the commercials for certain types of these stool-based testing and perhaps have gone through it yourself with your primary care physician in the office. Stool testing generally will look for blood in the stool, which is an indicator of something perhaps that is growing in the colon, but not always. And then the newer tests that are out there, that is testing for DNA in the stool. And that's a more advanced test that has been developed and studied and has great results in terms of being able to screen for polyps and cancer. Again, those are diagnostic tests, finding the problem once it's already there. So colonoscopy, as again, a lot of you already know, probably involves someone like myself, a gastroenterologist, taking a flexible tube and has a lens and a light at the end of it. Under sedation, that camera goes in through the rectum and goes all the way around your colon, from the bottom end to the top end. And the colon is shaped something like a question mark draped around the frame of your abdomen. The purpose of doing this obviously is to look at every square inch, square centimeter of the colon, not miss a single area, to find every polyp possible and remove them to prevent the chance that that polyp will turn into cancer. Essentially going through a colonoscopy, removing a polyp such as something that looks like this, making the colon then look like this after removal, resets the clock on that area of the colon so that all the tissue here that turned into this polyp that may have caused that polyp to turn into cancer is completely removed. That will heal over completely, look like the colon lining next to it, and the chance of colon cancer from that polyp is eliminated. So that's how colonoscopy prevents colon cancer, by removing polyps. CT colonography, or the CAT scan version of colonoscopies, is depicted here. And this is a less invasive test in that there is no instrument being advanced by a doctor through the colon. It uses CAT scans, which you may have had for other reasons, but essentially it's a radiation-based or an X-ray-based imaging test where contrast is put in through the mouth. You drink it, and it helps the radiologist look for problems within the colon, trying to recreate an image through different computer models through which the images are processed to essentially look like a colonoscopy. And this is what it looks like, a 3D image right here that has found a polyp in the colon. And then if that is positive, you do have to then undergo a colonoscopy to remove it. Obviously, a CAT scan cannot remove a polyp. So this is the correlate seen on colonoscopy for this same patient. And you can see that it is pretty accurate for large lesions. And CAT scan versions of colonoscopies have been proven to also help prevent colon cancer by finding these polyps, but still will require another test, a colonoscopy, ultimately to remove that polyp. It does still require a bowel prep, because you do have to clean out all the stool so that the CAT scan does not mistake stool for something like a growth or polyp. And it does require air being pushed into the colon, so there is some discomfort associated with that, but it has lower risks than those associated with direct colonoscopy. So the diagnostic tests are the stool-based testing we mentioned earlier, and the few versions of that, just quickly. So one is called occult blood testing, and some of you may have gone through this with your primary care physician in the office. This is a familiar card that we've all seen before. Center requires either a rectal exam or a spontaneously passed stool at home. Stool is put on the card, and the enzyme that's in the bottle helps us detect blood from anywhere in the GI tract, and that means it can come from your mouth, your stomach, your intestines, or your colon. So that's good and bad, because it can help us detect any blood loss from somewhere in the GI tract, but sometimes it can be blood from the stomach can be confused for that from the colon and vice versa, so it's not very specific in terms of colon cancer. There are some dietary limitations also associated with that, because if you eat, let's say, a rare piece of steak, that can cause this to be positive, because there is blood in steak as well and other animal meats. So this card does not differentiate between human version of blood and other blood. Immunochemical testing is a little bit more accurate, and that's because it is more specific for blood that is from the colon, from the lower GI tract, just because of the way that it is designed. Again, it's a test that's usually done more so at home on a spontaneously passed stool, meaning a bowel movement that you just have at home. And a brush takes a sample of that stool, it's put on the card, it's usually mailed back to your doctor's office. And again, it's testing for blood as a surrogate for something growing in the colon, whether that be a polyp or cancer. Again, it's a blood test specifically. The DNA testing has kind of supplanted most of that because it's more accurate, essentially. It detects human DNA in the stool, and we know that human DNA makes up a small percentage of stool. And over, a number of very talented researchers over time have essentially figured out what mutations are being shed by colon cancer or polyps into the stool that we can find on the outside of the body without having to go through an invasive procedure. So it's actually quite accurate, 92% for colon cancer, which is pretty good. Compare that to colonoscopy, which is about 96 to 98% accurate for colon cancer. And this is just by going to the bathroom. High-risk polyps are also able to be detected by this test, which is very different from the blood testing in the stool, the occult blood and the immunochemical testing. So this can not only detect cancer, but can also find polyps. So this has replaced a lot of the other stool-based testing that we've seen in the prior slides. So why do we recommend screening? Why are we here? Why are we talking about this? And the reason is early detection. Finding something before it becomes a problem, or if it has already become a problem, trying to get it at an early stage so that the treatment that is needed for that is not as perhaps permanent and perhaps even toxic to the body. And the reasons that we know that these tests help is because we know what it takes for a normal colon cell to go through a polyp, through a bigger polyp, and eventually to cancer. That has been very well laid out in terms of all the DNA mutations that have to occur. And we also know how long it takes to go from here to there. And that period is about 8 to 10 years, which is what drives the recommendations for how frequently you need to get something like a colonoscopy for average risk patients. 10 years. If you don't find any polyps, even in 10 years, within that 10 years, if you have another polyp, it's going to take at least 8 to 10 years for that polyp to become cancer in most cases. So the science behind the problem drives the reasons for our recommendations. So once we find a early cancer, if it's detected on a screening test by stool-based testing or by colonoscopy, we can also treat it. And that can be treated with just something as simple as a colonoscopy. This is a patient of mine who had a very large polyp that had cancer in it. We were able to effectively remove that polyp and make this entire area, which looks pretty scary, and to this, which is absolutely nothing. A year later, this is his colonoscopy with a completely normal-looking colon. So that shows how colonoscopy not only can prevent cancer by removing smaller polyps, can treat cancer by finding it early enough, preventing the need for surgery, and leading to a normal-looking colon again. Finding it early impacts how patients do if they suffer from this disease. Dr. Cohen might talk about this a little bit more, and he is more expert on this than I, but generally speaking, if the colon and rectum cancer is found early and it's local, which means that it may just be in that segment of the colon or perhaps in a lymph node or two in that area, your survival from that colorectal cancer is much more favorable than if it has spread to more lymph nodes in that area, which is called regional disease, or distant, if it has spread to another organ, perhaps the liver, for example. So your survival and how your outcomes from this disease, colon and rectum cancer, are impacted by finding it early enough, and the screening methods that we talked about tonight are how you either detect it early or prevent it from happening in the first place. So to summarize, as my mentors always told me, the best screening test is the one that gets done. Colonoscopy is not appropriate for everybody. Maybe someone has had a complication, is fearful of the bowel preparation, has other medical problems that does not allow them to go through it. That doesn't mean that you should not get screening for colorectal cancer. It just means that you may need another test, one of the stool-based testing perhaps. And I hope I've shown you tonight that colon cancer can be prevented and effectively treated if found early enough. So thanks for your attention, thanks for your time, and we'll take some questions at the end. Thank you.
Okay, moving along here. I'm going to be talking about how we classify colorectal cancer based on stage. There's basically a 65% 5-year survival. This is actually 2013-14 data, not 2018-19 data. Survival is a little better, but nonetheless, let's call it around 65%. And this is the reason why screening and colonoscopies are so important. Because if you catch this disease at an early stage in a localized phase, meaning stage 1 or 2, you have a 90%, over 90% survival rate. And that's why it's so important, as we just discussed, to have screening, because this is a curable disease at its earlier stages. Then when we hit what's called regional disease, call it lymph node involvement, meaning more involved disease, is basically about a 70% survival rate. And then when you have distant disease, meaning metastases, only a 5 years, 14% 5-year survival rate. So screening changes a person living from at 14% to a 90% rate if you can find these early enough. And that's why if you gain nothing from this lecture, it's to have your screenings done in a timely fashion and see your gastroenterologist. So this is a slide of staging. And you can see stage 0 or stage 1 is early colorectal cancer. These are basically polyps that are going into the wall of the colon. Stage 2 is a little more advanced into the wall of the colon. Stage 3 is now having what's called lymph node involvement. And stage 4 means it has spread to other organs. So once again, on a simplistic level, stage 4 is something spreading somewhere else. It can be anywhere in the body, and typically in colorectal cancer, it could spread to the liver, it could spread to the lungs, it could spread to other lymph nodes or peritoneal disease, meaning in the belly itself. Stage 3 is still localized and limited and still very curable, and it just spreads to the lymph nodes around the colon itself. And anytime someone has colorectal surgery, the surgeon will take out a sampling of the lymph node, and usually that sampling has to be 12 or greater lymph nodes to have an adequate sampling. And if it's done in the proper way, that adequately stages a person. So anytime there's lymph node involvement in stage 3, stage 2, and 1 are earlier disease. I'm going to touch a little on hereditary causes of colon cancer because a lot of colorectal cancer is not hereditary, meaning it can be environmental, it can be diet related, but in terms of environmental factors, it's about 5% of the cases. If you can see these little spots here, this is someone called FAP, or familial adenomatous polyposis, which is a disease related to multiple little adenomas throughout the colon. I'm going to skip the middle one and talk a little more about that in a second. There's another MTYH-associated polyposis, or MAP, which is a recessive gene. And more commonly, if we're going to see hereditary cancers, we see something called Lynch syndrome. And Lynch syndrome is important to notice because Lynch syndrome not only presents patients with colorectal cancer, patients with uterine cancer can also present as Lynch syndrome. Patients with kidney cancer, certain type of kidney cancers can present as Lynch syndrome. And we're going to talk a little about, in a minute, about in the treatment, because it's important to define what the underlying hereditary causes are, which may assist in the treatment options for our patients. So this is a very important slide for me because as an oncologist, I've seen patients now that are 20, 25-year-olds with colorectal cancer, and it's somewhat horrifying to see young patients with colorectal cancer. And over the past decade, the age of colorectal cancer has been getting younger and younger. It's not, although it is an older person's disease, there are clearly younger people getting colorectal cancer. This is why Dr. Akhtar discussed the guidelines and why the American Cancer Society has shifted their guidelines to go 5 years earlier. Because when you have a young person who's 35 in your office who has colorectal cancer, and they say, well, what did I do wrong? And you say, nothing. There's nothing you could have done differently in terms of screening. It's important to know that the guidelines have shifted a little earlier, 5 years earlier, for asymptomatic patients. That's American Cancer Society guidelines. So we are screening patients now younger than we did a couple of years ago because of this shift. You can see the colorectal cancer rate in 2004 and a young population was 11.5%. And young is defined as, let's call it less than 50. It increased to 14%. So it was about a 3 to 4% increase in just 10 years of younger patients getting colorectal cancer, which is, once again, the reason why you have to pay attention to what's going on in your body, change in bowel habits, change in stool habits, blood in the stool, things like that need to always be paid attention to because of this shifting demographic. So not only are patients being diagnosed at a younger age with colorectal cancer, their cancer seems to be a more aggressive colorectal cancer. That may be because they address it at a later stage, meaning patients who are younger don't think that they have colorectal cancer, obviously, so they may let things go a little longer until they finally come to medical attention, as opposed to an older patient who says, well, it's time for my screening, I might as well go anyway. The younger patients don't have that alarm go off saying it's time for my screening. So these patients tend to have more aggressive cancers, and they are younger, and our population is getting younger. So early colon cancer may have no symptoms. This is a cute little cartoon of colorectal cancer. You can be constipated, you can have diarrhea, you can have blood in your stools, you can have narrow stools, meaning change in the caliber of your stools. You can have unexplained anemia, and there are plenty of patients, and that's why even a simple going to your primary care physician and having a simple blood test and he sees you're anemic, one of the things that should come up on the alarm screen is, can you have a polyp that's bleeding? Can you have colorectal cancer? Tender in the belly or abdominal pain. Certainly unexplained weight loss is an alarm bell for anything, not just colorectal cancer, I would say. So if anyone is in your family or friends are losing weight and you say, oh my God, you've lost so much weight, and they say, well, I feel great and I'm not even on a diet, that's not so great all the time. They should maybe see their doctor. And weakness and fatigue, but that's all tied into being anemic, having maybe blood in the stool. So these are some signs that shouldn't be ignored for colorectal cancer. So in oncology, some of us have defined colorectal cancer as left versus right-sided. Left-sided tumors, meaning colorectal cancers down your left side of your descending colon, can present as change in bowel habits, blood in the stools, and the biology could be a little different than patients who have right-sided colorectal cancer. These can be what's called KRAS wild type, and we'll talk a little about that in a second, or EGFR-driven tumors. So those are responsive to different agents than in contradistinction to your right side of your colon, which are usually a little more aggressive, what's called BRAF-driven, which is a little less sensitive to chemotherapies, and patients who can't use certain drugs called EGFR agents. There's a drug called Vectibix and a drug called Erbitux. And they also can present as iron deficiency. So I just listed here, unrelated to left versus right, poor prognosis signs, which could be obstruction or perforation. Patients who just simply say, I'm constipated for a week or two, and that would be a bad sign. And if you're feeling well after not having your bowels moved in 2 weeks, then that's not a good sign. Nausea and vomiting is another sign of a poor prognosis, can be related to bowel obstruction. So rarely you can have what's called an abscess formation or fistula formation related to colorectal cancer. These can be a little later stage. So it's important to pay attention to your body and look at your stool once in a while and making sure that you're not having any new issues. And these are symptoms of metastases. So metastases, once again, just by definition, is what we call stage 4 colorectal cancer, meaning colorectal cancer that has spread beyond the colon. 20% of patients can present with stage 4 colorectal cancer. Common sites, as we just mentioned, were the liver, which is very common in rectal cancers, lungs, peritoneum, and lymph node. So this is your colon once again. This is the bottom, the rectum, going up, what's called the ascending colon. This is the transverse colon. This is the descending colon. This is the end of your colon itself. You can present as pain, abdominal distension, feeling early satiety means you're feeling full earlier, and you can have some nodes. If you feel any bumps or lumps in your stomach, that should be addressed. But not everyone presents with spread of their disease, meaning they could actually feel well, get a colonoscopy, and we're going to talk about other diagnostic tools that we use to what's called stage a patient, meaning see where the cancer is. So a colonoscopy in terms of diagnostic clues is the way we can initially find the colorectal cancer. But imaging studies like CAT scans, which are CAT scans of the abdomen and pelvis or chest, abdomen, pelvis, to look into the liver itself, the lungs, and the rest of the belly. I left off this slide, but PET scans would also be helpful in evaluating patients with colorectal cancers. There's no specific blood test, and my patients always say, well, my blood was all normal. That sounds wonderful, but that doesn't mean it's specific to colorectal cancer or any cancer for that matter. An anemia blood profile may look into someone who has colorectal cancer, but there's a tumor marker called the CEA, which is sometimes helpful for patients with colorectal cancer and sometimes not so helpful. And there are molecular tests and studies we're doing, which we're going to talk more about. These are the tests that oncology is shifting towards in terms of treatment options and therapeutic options. really to target certain therapies. So for instance, there's something called a BRAF mutation, an NRAS, and a KRAS mutation to see if they're eligible for certain chemotherapeutic agents, and something called microsatellite instability, and that has to go back to the Lynch syndrome, the genetic component of some colorectal cancers. So this is I'm not sure why they did this study, and I show this to you because I found it interesting that in Lancet Oncology, which is a prestigious oncology journal, they actually studied whether surgery is helpful or not, and early surgery is helpful or not. And they studied patients in England and Norway and Sweden, and only in Europe could they do this. They couldn't do this in the United States, this kind of study. And they showed the difference of survival between patients who had surgery and the patients who didn't have surgery. And the patients in England who didn't have surgery at more than 75 years was 60% had some, only 60% had surgery, and in Sweden 80% had surgery. And I find that strange because in the United States, the number should be like 99% who have surgery, not 60 or 80%. So fewer patients lived when they weren't offered surgery. It's like almost saying there's a great study by the NIH. They put $100 million into the study, and they correlated intake of food to obesity. I mean, meaning surgery cures patients who have colorectal cancer. And it needs to be done in a timely fashion. And really, as an oncologist, we use our gastroenterologist, our colorectal surgeon to quarterback the cases so our patients can move quickly through our system to go from one doctor to the next to do the appropriate next testing. So let's talk about the treatment options here. I'm going to divide this into two categories. The treatment options for early stage colorectal cancer, which is stage 2 and 3, and then we'll talk about metastatic colorectal cancer, which is stage 4. Early stage colorectal cancer, stage 2 and 3s, there basically is one typical regimen that we use is called Folfox, or another regimen called Zelox. I'm not going to go into the specifics of the drug, but it's either a drug called 5-FU or a pill called Xeloda with another drug called oxaliplatin. And it's typically given, and we'll talk more about how long the duration is, between 6 and 12 cycles of that therapy. For stage 2 colorectal cancers, typically we only treat those patients who have an inadequate lymph node dissection, meaning if the surgeon went in there and only got 2 lymph nodes and no more lymph nodes. If there was bowel obstruction, they're poorly differentiated, or they have what's called lymphovascular invasion or perineural invasion. Those are called poor prognostic factors on early stage 2, and those patients, since they have a higher risk of recurrence, would need some form of chemotherapy to reduce the risk of systemic spread. Stage 3 colorectal cancers, which are low risk, meaning only a few lymph nodes or earlier into the wall, can actually get by with 3 months of therapy versus 6 months of therapy. And actually, as of 2 years ago or a year and a half ago now, everyone got 6 months of therapy. But if you're a lower risk stage 3, meaning fewer lymph nodes or less involvement into the wall of the colon, you can actually get only 3 months of therapy or 6 cycles of therapy versus 12 cycles of therapy. And the reason for that is actually the survival was the same if you got fewer treatment, but the side effects of the therapy was something called neuropathy, which is numbness or tingling related to the chemotherapy, actually dramatically went up if you went to 6 months to 16% versus 3% at 3 months. So I have adopted in my practice, I don't think everyone has adopted, but for earlier stage 3s, meaning if you have 1 positive lymph node, I only give 3 months of therapy, not 6 months of therapy for those patients. If they have multiple lymph nodes, then meaning their risk is higher, then it is warranted to give a longer course or duration of therapy.
Is the neuropathy permanent?
The neuropathy is variable, and there are 2 types of neuropathy with the drug called oxaliplatin. One is an immediate type of neuropathy, or what we call a cold-induced neuropathy, meaning if you were to drink or hold a cold ice cubes or cold things, you actually can get a neuropathy or numbness and tingling related to your colorectal cancer. And then there's a delayed or more permanent type of neuropathy that is cumulative in its effect. Some patients, it comes and it goes away, and other patients do have some permanent neuropathy. The issue or problem with neuropathy, in my opinion, is that a lot of times there are no great treatments for neuropathy. And we use drugs like Lyrica, I'm sure you've seen those commercials, for diabetic neuropathy. This is chemotherapy-induced neuropathy. There's drugs like Cymbalta, which is helpful sometimes. There are procedures called microvasc, which is helpful sometimes. Physical therapy is helpful sometimes. But in all comers, neuropathy, if it's very severe for a patient, meaning if they have underlying diabetes or alcoholism as a problem, their neuropathy typically is going to be a lot worse than the standard person without any other side effects. So yes, it can be permanent in some patients. It can be tolerable and functional in other patients. We're going to move on to metastatic disease, and this is disease, once again, that has spread beyond the colon or the rectum for that matter. And there are various regimens we use. It almost sounds like alphabet soup here. Folfox, Folfiri, Folfirinoxaviria Avastin, and Vectibix. But these are the regimens we typically use either in first or second line patients who have disease that has spread beyond the colon. But I'm going to pivot in a second here to a recent study called the Beacon 3 study. And this was a study that showed what's called BRAF mutation. So when they get out colorectal cancer, we do specific markers, or I do specific markers on patients who have colorectal cancer. And that's to see if they're eligible for other targeted therapies or other unique drugs. So BRAF V600 is a mutation that typically patients have a shorter survival, meaning it's typically much more aggressive than standard colorectal cancer. So not all colorectal cancers are the same, and you can have two different patients or two patients in your waiting room, one that has metastatic disease that is 3 to 4 years out, and another patient who's only a year out, and the person who's only a year out is having major issues or not tolerating the chemotherapy or the disease is progressing, and sometimes that's clearly related to the genetics of the disease. So this is a recently, released study that showed 2 agents that are given for BRAF V600 and a drug called cetuximab actually had a response rate of 50% and increased survival from about 4 to 6 months to over 15 months. So this is the next wave of therapies that we're going to be using on our patients, which is really targeted therapies with some immunotherapies, and that's what we're going to discuss next. I'm sure if anyone watches TV, they will be inundated with grandma and grandpa who's on Keytruda, or grandma and grandpa who's on nivolumab or Opdivo for various cancers. And the truth is, these are fantastic agents. Unfortunately, in colorectal cancer, they're not all cracked up as in other cancers. For instance, in lung cancers, if you're a high PD-1 producer or you have a high score, those patients typically respond better. In colorectal cancer, the subset of patients that these agents work well is called MSI high patients. Those are the patients with Lynch syndrome. Those patients respond well to the immunotherapies. So in general, immunotherapy has been somewhat difficult for colon cancer unless you are at MSI high. This is a recent presentation, I think from Toronto, just a few weeks ago, that combined a drug called durvalumab, which is a PD-1, which is with another drug called CTLA-4 agent, which is, there's another drug on the market called Yervoy on the market right now, which is a CTLA-4. And they improve survival minimally, but there's at least some movement of the pendulum here to see if there's some activity in patients with immunotherapies. And then finally, I'm going to finish off on these 2 other drugs, which are nice oral medications, but in truth, in terms of efficacy, not so great. But in some sets of patients, they work. There's a drug called Lonsurf, which is an oral drug approved in 2015 for 3rd or 4th line agent as chemotherapy, and another drug called Stivarga, which, as you can see, improves survival by 1.4 months, which is not so impressive, but it did move the pendulum as well, and it is convenient for patients to take an oral chemotherapeutic agent at home as opposed to an IV chemotherapy. So colon cancer, first of all, I hope you gain from tonight that it's preventable by colorectal screening. It is treatable by our new agents that we have coming aboard and the other research that is being done. And with everyone's help, everyone should get tested and look and be careful. Thank you for your time tonight, and me and Dr. Akhtar will take some questions at this time.